in a country like Uganda, there's 48 million people. They have one heart failure clinic for the entire country. People travel for days to get to clinics and so on. We started playing with some LLMs there, and and this was mentioned in other studies, is that people in those countries are much more amenable to the use of AI than we are here in the Western world, in wealthier countries. And they look at this as a huge opportunity. And, we were using some of these LLMs to help inform some of the nurses in these rural areas where there's no physicians and they're on their own. And they have huge scope of practice in these nurses in rural Uganda, where they can treat and prescribe medications. And some of the nurses who were using these LLMs for this purpose, they said, do you know what? Could we not just give this directly to the patients? Some of them travel for days to come to this rural clinic, only to find out that we don't have the medication or the clinic was closed.
Do you think we just get so used to the status quo that we forget that if we're not innovating and progressing, we're actually falling behind?
Well, I think there's a lot of self-interest in there. And I think, getting on to my next pet peeve, when it comes to access, and I think there's a reckoning coming, is that especially what I've seen over the last month or two, it's the studies coming out, is that artificial intelligence is an inevitability. And I think healthcare is going to be told kicking and screaming towards it, right? Other industries are going to be adopting it. But in healthcare, we're going to have a lot of trouble because we still believe that what we have now is going to be better than, and if AI is not perfect, then we're not going to consider it. But we're not recognizing the baseline, right, of poor access and, quite frankly, error-prone humans, right, with all the cognitive biases, recency bias, and so on. I have seen incredible things from artificial intelligence. Every time I read the next paper that's come out, the work that my students are doing, I am continually blown away by the progress. And we're just kidding ourselves. And to me, this is an opportunity that we need to embrace. Obviously, it has to be safe, but we got to recognize that what we have now, in many respects, is unacceptable. And in many cases, people have nothing.
How can AI augment patient care and patient safety?
Well, it does have a multiplier effect, right? And I think some of the work that's been done at Unity, right, at St. Mike's, they have this concept of chart watch, and I think it's going to be replicated. But can you imagine, an AI system constantly monitoring all the parameters in the EHR in real time, right? There is no clinical inertia of waiting for that physician to log in and look at those lab results, right? There's the potential for in real time, sepsis management, lab results, test results being actionable immediately. And so that's an obvious choice. But also, just getting patients access to information and getting them access to potential treatments faster, and that multiplier effect, right? If it takes a physician much less time because they have the second opinion, this system that is prompting them to make the decision. I'm not suggesting that to take them entirely out of the loop, but there is easily an opportunity to make the AI a multiplier effect of that specialist or that family doctor.
Why are we hesitant to adopt it? Is it just because we think that it's not perfect?
Precisely, Ryan. People are always citing hallucinations. And yes, there are hallucinations, but we've been talking about hallucinations now for about 2 or 3 years. The hallucination rate has gone down, And in some of the more reasoning models, the models that are more system two thinking rather than system one thinking, the rate of hallucination is far less. If the AI models is connected to an information resource like the internet or, a knowledge base, the rates of hallucination are far lower because it tends to hallucinate on subjects it knows very little about, right? LLMs want to please the user, so they give you answers and sometimes quite convincing answers until you look them up, right? But again, if it has access to information, if it has access to custom knowledge bases, the hallucination rate goes down dramatically. And there are biases in it because they've been trained on, the totality of human knowledge. But if you compare it to the fallibility of human beings, because if you are a clinician and you have not seen a particular condition or a confluence of symptoms for a very long time or never, you're going to have a difficulty with that diagnosis. And these AI models don't have that difficulty because they are going to look at all possibilities. And I think it's anecdotal now, but you see a lot of examples of people with relatively rare conditions being saved by AI, that they've been going around, shopping around to multiple physicians and being told they're either crazy or don't worry about it, and they're deteriorating. And it turns out that they have a rare condition, which only the unvarnished, unbiased LLM, which will give you every possibility as to what your confluence of symptoms are, will tell you.
Right. So we look at the human factors of humans. Why are we so prone to bias then? And their AI is not. Like, why are we prone to recency bias?
Rare conditions are simply that. They're rare, right? And LLMs are, although they're modeled like us and the human brain, right? They are not. They're not like us in any other way. So, despite the fact that they're a matrix of neural nets, they're perhaps oversimplified. And as a survival technique, if we were worried about everything, like all possibilities, we wouldn't get anything done. So it's probably for self-preservation from a human factors perspective. We have, our attention, and we are processing far more data than any current AI model can through our optic nerve and so on. I can sit here and talk to you without interruption, despite the fact that I'm hear noise beyond my my door here. And if I was to process all of that information constantly, we wouldn't get anything done, right? So it's probably a bit of our ability to survive in order to have attention and keeping that attention on things that are of immediate importance and so on. So that's the fallibility of human beings. And I don't necessarily want to dwell on them. Can you imagine a human being being coupled with this technology that is going to point out, that rare instance, right? That you were never trained on. And the other thing I like about them is that, we go to specialists and it takes an entire, career to become a cardiologist or an oncologist and so on. With these models, they are all specialties. And that's part of the challenge in healthcare today is the level of comorbidity that patients have. And so, you could split hairs and say that at any one time, this model is not as good as a real cardiologist, but that cardiology LLM can also do pediatrics, can also do oncology, can also do respirology, et cetera. All right. So that's what really kind of amazes me about them.
So basically, if we used it as an augmentation to all the specialists to have like a second lens to say an unbiased view and just grasp all the bandwidth of data out there to help make the best clinical decisions.
And also perhaps getting rid of a lot of low value care. And that's something that we've been thinking about is that, if the lab results and the imaging comes back, and the AI model says this patient is stable, do not have them come to PMH from who knows where, sit in a room for 2.5 hours for you to come out the door and have a 3-minute conversation with them that your PSA is normal, you're doing fine, see you again in 6 months. Please don't do that.
So trying to mitigate the waste as well
Yeah.
from the patient perspective, clinician perspective.
Yeah. And I think there's a lot of new models of care that are, digitally mediated and maybe nurse led instead of physician led, and that are augmented with these AI models. And you could see a path where you've got the human touch. And again, it may be another health professional and not a physician. And the physicians are only doing, uh, or taking the harder cases or where a medication needs to be titrated or a new diagnosis or new symptoms are emerging and so on, but not for the routine chronic disease management. I think we need to get patients to do that themselves more with the technology, augmented with the nurses. And then the last resort is the physician in the hospital setting. I do know that there's some concern about physicians. Physicians have said to me, Joe, if you get rid of all the well patients and I only have the sickest of the sick patients, I'm going to lose my mind. And I am sympathetic to that, because sometimes you do need, that patient who, was cured, or you remove that tumor 10 years ago and they're thriving. And sometimes you need that win. And so I understand that aspect of it, is that, it could burn out physicians very well as well. And so, I'm not saying that it's going to solve all problems.
And that goes back to the human factors, people just wanting to actually see healthy people and what they've done actually works. I can appreciate that too. How would we design AI, in other terms, to improve patient safety and improve system designs for patients and clinicians?
I was just playing with it earlier today, but I had this multimodal model, a vision model, right, on my phone, and I directed it towards an infusion pump. And I just had a conversation with it. It could see, I said, do you recognize what this is? And it said, it's an infusion pump. And I said, well, okay, let's do this. Walk me through the process of doing an infusion and point out some of the design flaws in this using Nielsen heuristic. And I didn't train it. This is probably based on ChatGPT 4.0. And we went through it. We did an infusion. We loaded the line and we walked through the user interface. And I said, make notes of where the UI could improve. It was astonishing because it was never trained for any of this, right? I mean, that's one example from a more professional perspective on the use of these models for developing new products. And there's all this notion of AI being used for programming, right? What they're calling AI coding or vibe coding, which allows, lay people with a good idea to start writing applications, right? And you don't need to be in the weeds of understanding really esoteric programming languages. But I think in, closer to home, patients are going to have, it's almost like what happened in 95 when, Dr. Google happened, right? When people could start searching, right? It's one thing getting access to information. And, we had trouble with the early days because there's a lot of, and even more so now, probably a lot of misinformation on the internet. And it's not to say that there are LLMs are going to be perfect, but they are better than what we had before, or they're better than nothing. In low and middle income countries, we have this project in Uganda with Yale University. And what amazes me about these countries where there's very few resources, in a country like Uganda, there's 48 million people. They have one heart failure clinic for the entire country. People travel for days to get to clinics and so on. We started playing with some LLMs there, and and this was mentioned in other studies, is that people in those countries are much more amenable to the use of AI than we are here in the Western world and in wealthier countries. And they look at this as a huge opportunity. And, we were using some of these LLMs to help inform some of the nurses in these rural areas where there's no physicians and they're on their own. And they have huge scope of practice in these nurses in rural Uganda where they can treat and prescribe medications. And some of the nurses who were using these LLMs for this purpose, they said, do you know what? Could we not just give this directly to the patients? Like, I mean, some of them travel for days to come to this rural clinic only to find out that we don't have the medication or the clinic was closed. Could they not closer to home use this? And I think the other thing I'm amazed is that, literacy levels are actually quite low in those rural areas as well. But these large language models are now multimodal, and you don't need to type in anything. And again, if you have low literacy, you can just speak to them. And it just so happens that phone penetration in Uganda is more than 100%. People have multiple phones, and it's the only way they can communicate. They use it for mobile money, quite sophisticated in other respects. So ironically, we might see the adoption of AI in healthcare in these low resource countries before we see it here. And it's largely based on the fact of need and being able to access something instead of nothing.
There's 2 points there that I love, and correct me if I'm wrong, but the large language models are designed so well and so user-friendly that someone with a low literacy and reading and writing can still operate it effectively, which is brilliant. And secondly, it's interesting that us in a first world country, by our perceived resources we have, don't adopt it quicker than countries that have nothing, but they're just like, this is the best thing we can do. Let's use it as best as we can.
Yeah, and it is going to open up lots more in those countries because, again, some people have never been able to access the internet because of low literacy. Like if you don't read or write, you can't really use the internet. But if you can speak, now for the first time, you can interact with a model that can speak your language as a conversational agent and have access to information that you need.
I want to be mindful of your time, so I'll ask this last question.
Sure.
At the end of your career, for you to be like, that was a success, I helped the most people through user design, human factors, what would make that threshold?
The safety work has been important to me, but I think the biggest contribution I feel I could make, and I still feel I have some ways to going, is it's helping to improve access. To me, we are pretty proud of the Canadian healthcare system, but it is really fraying at the edges these days. And how can you be proud of a system that you do not have access to? I think part of the problem is that we're comparing ourselves to the US, which is a very low bar globally. And so that concerns me a lot. And in order to really see the benefits of technology and good systems design, is that we need to solve the access problem. And I like to think that I'm contributing to that in some ways, but there's lots of work to do.
I can assure you, you are. You're doing incredible work, and same with the other profs at UHN and Queen's University and all the other employees. So thank you so much for coming on and sharing your wisdom. You're always welcome back.
Thanks, Ryan. Pleasure.